business, so he'll be here in a little bit. Dr. Zhao just got back from the Heart Rhythm Society, and he was going to kind of give you an update on what was new from the meeting. But I thought one of the things we get a lot of questions about, this will be more of a question and answer rather than a defined talk as much, was nutrition. I think everybody's bombarded by nutritional information. Eat this and you'll live longer. Avoid this, you'll live longer. So this article I've got here is from the Journal of the American College of Cardiology, and Sharon made copies for everybody. And this kind of summarizes what the world authorities in nutrition know about the value of certain foods. What's good, what do we know is bad, and avoids all the hype. You know, nowadays every type of vitamin is promulgated, you know, for this or that. Most of these claims make their manufacturers a lot of money, but there's very little scientific data, for example, that any of these things work. So I'm going to refer to this handout, and if you go to page 2, you're going to see some of the things that we'll discuss a little bit in terms of different oils. I mean, everybody's heard the olive oil Mediterranean diet promulgations in the news. Sunflower oil, olive oil, palm oil, antioxidants. Who's not heard that everything's an antioxidant, right? So this is going to give you a guide about what works and what doesn't work. So if you turn to the next page, let's just talk about a couple of these. So if you go to page, or table 2, it takes up the whole page. Let's just talk about something. And we talked about the Southern dietary pattern. So there was a huge study published in 2015 in 17,000 subjects, and they classified eating patterns into 5 different types. One was eating for convenience, one was plant-based, although it did contain dairy, poultry, and fish. One was a sweets-based, and one was sweets-based with alcohol and salad. And the Southern pattern, everybody know what the Southern pattern is?
No.
Fried food. Heavy intakes of fried foods and added fats, eggs, and organ meats. And sugar-sweetened drinks, which I'm having one right now, Coke. And so when they looked at this, there was a 56% increase in cardiac events over 6 years with the Southern pattern. So a diet rich in fried foods, at least in this 17,000 patient study, everybody says to avoid fried foods, and you say, well, how do we know that? Well, this is the basis of that study, and it's quoted in here if you want to read it. In fact, you can look up any of these studies if you punch them into Google. But that's a pretty big increase, right? 56% increase in cardiovascular events just by eating what we call the Southern pattern, which we, if you look at patterns of heart attacks, Louisiana, Mississippi, Alabama, the whole South has got a higher heart attack incidence than anywhere in the country. It's called the heart attack belt. So there's something maybe with this about dietary intake. Okay, so that's called the Southern diet. And how do you avoid the pitfalls of the Southern diet? You avoid mainly fried foods, which is hard, right? Everybody wants to Popeyes every now and then. What about dietary cholesterol? This is where you get into a lot of controversy. There's 2 studies, Hopkins and Wegmans, where they did anybody know what a meta-analysis is? That's where they take every study and try to combine them. They're fraught with a lot of statistical downsides, but what they found in that study, if you look at the key conclusions, it basically tells you the bottom line. They said that added dietary cholesterol increases serum cholesterol. Well, that's not anything new. And the effect is greatest when the baseline intake is low. And each 100 milligram increment in dietary cholesterol increases total cholesterol by 2.2. So it basically says if you eat a high cholesterol diet, your cholesterol is going to go up. Okay, so there's the science behind that study. What about canola oil? Anybody cook with canola oil? Anybody believe in canola oil? Okay. Well, there's actually a study published in 2013 by Dr. Lin, and it was a systematic review of 31 randomized trials, and it said that canola oil reduces LDL cholesterol, but it had no effect on HDL cholesterol, but there was no data whether it actually prevented heart attacks. So it may actually be of some benefit. So the current recommendation as of 2017 is as a plant-based oil rich in unsaturated fatty acids, canola oil can be used to replace other fats. Okay, so this is, there's some credence to that usage of canola oil. That's actually borne out by some scientific data. What about coconut oil? Anybody use coconut oil?
Our doctor has us taking coconut oil capsules as a brain aid,
Okay,
but this surprised me. What does SFA mean? And
on coconut oil?
Yeah, it says it's rich in SFA.
Because it's rich in saturated fatty acids, its use is not recommended in large amounts. Now, your doctor's using it as a brain supplement because it's got phosphatidylserine in it. Yeah, there may be some benefit in that, in small amounts in capsules, but to use large amounts of coconut oil is not recommended because it's full of saturated fatty acids. So the current data doesn't suggest using canola oil as part of your cooking oil as a factor.
Coconut.
I'm sorry, coconut oil. What about sunflower oil? Who's a sunflower oil proponent? Okay, so what's the data on sunflower oil? Sunflower oil is rich in different types of beneficial fatty acids, and it can be used to replace other fats. So the use of sunflower oil is actually, as best we can tell in 2017, maybe of some benefit. I've never had, you ever cook with sunflower oil, Sarah? Okay, you're gonna start there.
Nope.
But we use sunflower seeds.
Now, olive oil. I don't know, I'm a connoisseur of olive oil. I grew up in an Italian family with
That's us.
my grandmother cooking the best stuff in the world. And so you go in a grocery nowadays, you go to Doranax, and there's like hundreds of brands of olive oil. You got to be careful because there's been some chicanery on the market where some of the oils have been diluted with stuff that's not so good. And I'm not an expert in how you pick out the good from the bad, but there's a huge amount of data on the so-called Mediterranean diet. Anybody here follow a Mediterranean diet? Okay,
We're in the
I'm
South.
surprised. What's
We're
that?
in the South.
Yeah, we're in the South, we eat fried foods. I bought lunch for the West Bank office today, and they ordered from a place called Perino's Boiling Pot, and nobody got anything everybody was fried. And I looked at it and said, everything's fried, you know, this is not a good diet. But that's what people like down here, is fried food. You go to Deanie's, anybody go to Deanie's?
Oh, yeah.
They kill you. That place is, it should be banned as a public health hazard. I mean, not just a little bit, they just pile it on. Of course, that's what makes it attractive. People
Yeah,
think they're getting something for their
But they
value.
have boiled potatoes
Oh, I
on the
know.
table.
They got
So-
some good things there. So let's look at the data on olive oil. So there's a lot of data, a lot of scientific data on olive oils. So meta-analysis, again, they lumped the studies together. Randomized trials demonstrated beneficial effects on inflammation. What is inflammation? If you rub your hand with sandpaper, it gets red. Why does it get red? It's because the blood vessels dilate, right? And inflammatory cells go there. Inflammation is one of the prime causes of heart disease, okay? Why does a patient who have a 20% blockage versus a patient who has a 50% blockage and a 20% blockage comes in with a heart attack? Why is that? Well, we know those patients who have even a smaller amount of blockage, if they're in a high inflammatory state, for example, we know patients with rheumatoid arthritis are in a high inflammatory state, what happens is those plaques tend to be unstable and rupture. So olive oil is actually an anti-inflammation agent. You see other things being advertised now like turmeric and ginger and a whole host of other things. Those are purported to have some anti-inflammatory effect. But olive oil is a prototypical anti-inflammatory. And it's a key component in the Mediterranean diet, right? I mean, olive oil comes from olives, and, you know, I love olives. They're good. So there's actually real data here. So there's a study called a Predamid study. There's a called the Predamid Nutrition Intervention, item number 3. A Mediterranean diet supplemented with extra virgin olive oil for 5 years reduced cardiovascular events by 30%. That's a huge, huge, huge decrease if you want to look up that study. So extra virgin, meaning unrefined olive oil, is rich in monounsaturated fatty acids. And there's other chemicals called polyphenols. Polyphenols are chemical substances that are anti-inflammatory. And there's, in study after study, consistent evidence of its beneficial effect on heart disease. Okay? There's also data that a Mediterranean diet results in lower amounts of Afib. Because Afib is a highly inflammatory condition also. So there may be some beneficial effects on adding olive oil to the diet, maybe replacing a salad dressing that's, dollops of one thing versus one based on olive oil. What about antioxidant-rich fruits and vegetables? Here there's a huge amount of data, okay? You've been hearing since you're a kid, eat more fruits and more vegetables. Well, nowadays that's never been more true. And basically, vegetables that are colored vegetables have polyphenols in them. Pick anything that's colored. Carrots, for example. Carrots have carotene and a bunch of other things.
Blueberries.
Blueberries are another great source. In fact, I know a lot of my patients do mix their own, blueberry, strawberry concoction. I think those are generally not only safe, but actually probably pretty beneficial. So there's actually quite a bit of data here. So there's a study by Cassidy and another one by Johnson. They looked at 93,000 women in what's called the National Heart Study 2 study. And it looked at the intake of an antioxidant called anthocyanin and the risk of heart attack over 18 years of follow-up. And they found a diet rich in those substances also had a 1/3% reduction in heart attack. You may have heard of a Dr. Gundy. He's a cardiovascular surgeon at Stanford. He left, but he promotes this high polyphenol diet. It's called the Gundy diet. Many of you may have gotten that. So certainly substitution of olive oil for other oils and an antioxidant-rich diet has some may have some definite effects. Now, when we get to supplements, the data gets a lot more confusing. Okay, years ago it was vitamin C, vitamin E. Okay, Linus Pauling promoted mega doses of vitamin C, 1,000 to 5,000 milligrams of vitamin C. And of course he lived a long life, so he was his own best example of it. But if you look at studies looking at antioxidant supplements, neither vitamin E nor beta-carotene supplements in a variety of trials really showed much effect on heart attacks events. And why is that? Maybe because the supplements are devoid of other things that make the antioxidant effective. We don't know. So it may be that obtaining it in a pure plant form is better than the supplement. I know patients, they bring their, and I'm not criticizing it, they've got a bag of supplements that's like, they almost have to wheel them in. High dose vitamin C, vitamin E, every conceivable thing, and it gets to be kind of expensive. But there's very little data when you look at the scientific evidence that supplements and pills really do that much for you. You're probably much better off substituting the pure food. Now there is some data about just nuts. Okay, nuts are part of the Mediterranean diet. I mean, nuts are a very primitive food, and particularly if they're not salted. The beneficial effect is negated if you buy the salt-rich ones. You got to get the, almonds without nuts, and don't fill them full of salt. But there's actually quite a bit of data that suggests that nuts are not only nutrient-rich, but in the Predimid study, the addition of nuts had a supplemental additional effect on reducing heart attacks. If we predispose that inflammation can cause both heart attacks and AFib, there's a lot of sound nutritional advice in here. Now the trouble is, people don't want to follow these types of diets, okay, for the most part. That's the trouble. So this is a good summary. You may want to read, this is nighttime homework reading, that you can take this article back. And of course you can look up any of these studies on your own. And if you look at, if you go to the next page, let's go down to the bottom and work our way up. There's this whole big issue now about gluten, right? Gluten-free, everything's promoted to be gluten-free. This is a study by Dickey in 2006 and another study by Ebling in 2012. And what they concluded was a gluten-free diet is not necessarily associated with weight loss. But a gluten-free, low glycemic index diet can increase resting energy expenditure and promote some weight loss. So there's two conflicting studies on that. Does anybody follow a low gluten diet? A lot of patients with irritable bowel syndrome are on a low gluten diet. So there's a lot of controversy about that. Okay? And so there's two other studies on green leafy vegetables and protein from plant sources. I'm going to allow you all to do that and read that. And on the following 2 pages, all the guidelines are summarized into this one big summary slide. And so what they did is they classified it as evidence of harm. The second column is inconclusive evidence for harm or benefit. And then the third is evidence of benefit. So what do we know are things that can hurt you? Okay? Coconut oil and palm oil are high in saturated fatty acids and do raise cholesterol. Now, eggs are very controversial because when I was a student, we were taught, based on some preliminary studies, eggs raise the cholesterol too much. There's a lot of data that eggs contain a lot of other good substances, so eggs should not be totally eliminated, so I disagree with that. If you look at the Southern diet, added fats and oils, fried foods, I don't think anybody should eat fried foods anymore. Sugar sweetened drinks, there's a lot of evidence that Cokes and, you know, I pretty much drink tea, but occasionally I need one for a little bit of energy. But Cokes are filled with a lot of bad stuff too, particularly some of the sweeteners are bad for you. Juicing of fruits and vegetables with pulp removal increases the caloric concentration. So if you juice a lot, be careful what you're juicing in terms of calories. What about the second column? Inconclusive evidence for harm or benefit. Sunflower oil is a big question mark. High-dose antioxidant supplements are a question mark. Gluten-containing foods, if you gluten avoid, that's a question mark. And juicing of fruits and vegetables without pulp removal is a question mark. So that's a big, we don't know. Now let's look at what we know beyond a shadow of a doubt. Things you probably should be doing is getting more extra virgin olive oil, eating more blueberries and strawberries because that deep, rich color is full of polyphenols. Okay, blueberries, strawberries, a variety of different fruits. Increasing the serving of nuts without salt. Increasing green leafy vegetables. Kale is a popular one right now. Kale is very nutritionally dense. Spinach is a nutritionally dense food. Iceberg lettuce is not. It's pretty much devoid. It has bulk, and it does help the colon in some ways, but it's not that helpful. And eating more plant-based protein. So this is everything that we scientifically know about food in terms of cardiovascular disease and likewise AFib. So I'm going to take some questions right now.
I didn't see any comment about fish oil.
Yeah.
Notice anything?
There was a recent study, I was reading the abstract on fish oil supplementation. Not all fish oil is created equally. It depends on the ratio of the different unsaturated fatty acids. The biggest meta-analysis trial showed for atrial fibrillation there did not appear to be a beneficial effect of fish oil supplementation. On the other hand, people whose diet contained a lot of natural fish, particularly oily fish, had a lower incidence of AFib. So sometimes that data is hard to interpret, but simply go on and get fish oil capsules may not necessarily help based on clinical trials. If you do use fish oil, you got to be careful because a lot of the fish oil is contaminated with mercury. So the brand I usually recommend, you can find at Whole Foods, I think is a safe one. I've studied and researched it. It's Nordic Naturals. It's got a good blend of the good stuff. It's a liquid. And in fact, some patients still take old-fashioned cod liver oil, which, you know, if it's prepared correctly, has very high nutritional benefit. And I've had several patients swear to me that after they took fish oil, their AFib disappeared. So there's a lot of anecdotal evidence about fish oil. But from a broad scientific standpoint, there's no randomized trial that suggested, you know, in everybody it helps. I'm not against you using it. Now you got to remember one thing about fish oil. Many of the patients in this room are taking anticoagulants, either Coumadin or Xarelto A variety of different anticoagulants, or alone or with Plavix and aspirin. If you add fish oil, which is a natural anticoagulant, you've got an increased risk for bleeding. So you have to be careful with fish oil supplementation. Fish oil is an anticoagulant in its own right. It's a weak one, but it may be enough to tip you into bleeding. So be careful of that. If you're taking Xarelto, for example, be careful. If you're taking Xarelto and let's say Plavix and aspirin, and you've had a stent, and you add fish oil, there's a chance that you may tip yourself over into bleeding. So be very careful about it.
What
Yes,
about
sir.
Redaxa? I mean, is that the same
Same
properties?
class.
Okay.
Yeah.
You
I'll
mentioned
come back
about
to you in a second.
eating a lot of green vegetables, but doesn't that have a lot of vitamin K in it if you want to?
If you're on Coumadin, that would be a big consideration for vitamin K. Because now, if you're on a stable amount of those large green vegetables, your person who's adjusting it can compensate for it. Okay, so those green leafy vegetables are chock full of vitamin K. What does vitamin K do? It reduces the effect of Coumadin. It makes you more prone to have blood clots.
And you mentioned something about ginger.
Well, I was just talking about the whole, patients are bombarded by all these things about these natural anti-inflammatories. Eat a ginger, or drink a ginger drink or turmeric drink, and you have less inflammation. Most of those claims are nobody's done a good study looking at the effects of these things on inflammatory markers. I mean, you can measure inflammation. You can measure something called ultrasensitive CRP, and we can tell whether you're in a high inflammatory state or not. There's very few studies that have looked at this, but these claims go out, you know, eat this, drink this, do this, and you're going to be better. You're going to feel better. You're going to be able to go run a marathon. All I'm saying is be very cautious, and you know, if you my advice is if you're tempted to see something on TV, just punch its name in Google and look for all the bad stuff said about it. Okay? Particularly some of those preparations that are sold are not of high manufacturing standards. Yes, sir. You had another question?
Yeah, what about the nuts? I understand the salt, but could they be roasted or do they have to be raw?
They're better raw.
The better raw?
And definitely without salt on them.
Yeah.
Almonds, pecans are very rich in good things. Plus they provide some bulk too. Yes, ma'am?
You mentioned the Plavix also with the fish oil.
I'm sorry?
The Plavix you were mentioning.
Well,
it has an
a lot of
effect.
our patients have coronary disease, blockages in the heart arteries, and they've had a stent. And the current guideline says you need to be on what's called dual antiplatelet therapy for a period of time. And usually the dual antiplatelet therapy is aspirin plus Plavix or Afib or Tigric, a variety of different ones that are available. But those drugs in combination don't prevent the stroke risk in Afib. You've got to add the anticoagulant like Coumadin or Xarelto, one of those agents. So what happens is you wind up getting put on Coumadin for the Afib and the dual antiplatelets for the coronary disease, and you got a recipe for bad problems. Then you add fish oil on top of it. You can see you just keep tipping that colon into bleeding.
And I was going to mention when you brought up the the olive oil. If I remember the primary care, it's good. It's good. That it's better than the other oils, but the best is to not to. They said it, when it goes in the heat, it alters the chemical of
Yes,
the bed. It's better in the raw.
It's better in the raw state. I use it on salads myself.
Right. My mama used to give me a teaspoon when I was a baby.
Yes,
when
it's,
we were little.
Some people do use the cod liver oils or the fish oils. I mean, we've got a lot of patients. But you have to be very careful with fish oils because of that mercury. You know, if it's not cold distilled, be careful about the preparation. Check any preparation. I always say, just punch it into Google and you'll see what people say about the mercury content, because a lot of the fish are in high mercury waters. The oceans are polluted, so you can get some, you may actually be doing yourself more harm by having high ingestions of mercury. And a lot of those are contaminated really bad with mercury. I know the Nordic Naturals, I've looked at their site and they have quality control and it looks pretty good. I have no financial interest in any.
Thanks.
Yes, sir?
You didn't say anything about dog chocolate.
Well, you know, that's interesting because I know you read the paper a lot, and we used to caution patients about chocolate because chocolate has theobromine in it, which can, we think, trigger AFib. There's a recent study that was published that suggested that the beneficial effect of dark, rich chocolate outweighs that by virtue of its polyphenol content. Polyphenols are those chemicals that are anti-inflammatory, the ones that are found in all those brightly colored berries and things like that. So there may be some beneficial effect of dark chocolate. I have to go back and reread the study and look at the criticisms before I would suggest that patients take it. But there's some data about dark chocolate, not only in AFib, but also in coronary disease. So I'm gonna leave a big question mark on that one. But you may have, there was a big article in the paper about a week ago about dark chocolate. Anybody see it?
Rich?
Makes you want to go to Belgium and go to those chocolate stores.
Nobody sent me to Walmart to eat some, and I don't like dark chocolate, so, but I am.
Any other?
If you're on an anticoagulant, and in spite of that, you wind up with the blood clot in the brain, can you use a clot bust on you?
Yeah, they can, but you're talking about if you're already on an anticoagulant?
Yes.
They're going to be very, 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 very leery about doing it. If you're in a good stroke intervention center, they would actually go in and try to get the clot out if you present very quickly.
As opposed to the blood clot.
Yeah, because the risk of bleeding is higher. And every person has their own threshold for it.
Okay, thank you.
Any other? Now, Dr. Zhao was at the HRS meeting. You may want to have some questions about new technologies he may have seen for AFib. I didn't see any big revolutions coming, but you know, we're kind of stuck sort of at the same place we've been at for a while.
You're
Yes, sir.
true. Not too much exciting things.
Not too much exciting. I mean, we're kind of stuck on that, I don't know, we've been at this plateau where if you have come and go paroxysmal AFib, your success rate with the cryoballoon or with radio frequency done well is roughly 70 to 75%. You can argue the number each way a little bit, but it's not 100%, which is disappointing because we don't like putting anybody through procedures and have to go do them again. We try everything we do to not go do the same thing twice. Now, for persistent AFib, the numbers are much, much more disappointing. They're really disheartening. If you've been in AFib for more than a year, we like the hybrid conversion approach, but it is a big procedure. It has risk. We find there is some late attrition, that even when we get a good result at a year, that when we follow out 2 or 3 years, there's a certain number of patients who have more problems. None of us, I think, Jen would agree that we don't like to use the term cure. We used to think that we could cure AFib. I'm convinced now that I mean, there are patients who do get, quote, cures, meaning if at 5 years they've had no, it's like cancer. I mean, can you ever be sure you're not going to get cancer again? They talk in cancer about 5-year survival and 5-year remission. I think we should use the same concept with AFib. You know, we try to keep your normal rhythm as long as we can, but I don't think there's a guaranteed cure of AFib right now. With one exception, the really big procedure that Dr. Cox invented, the Cox-Maze 4, where they actually open the chest, and no one here has had that, I don't think. That effect lasts a long time. Success rate with that is well over 95%, but it's a big operation. Dr. Brothers does a nice version of it that's less invasive, but it's not a cure problem.
Well, if you,
Just a minute.
if you are in persistent 24/7 AFib, does exercise causing a higher heart rate damage the heart any?
There's no data that that's the case for short periods of time. Now, if you stay at elevated heart rates day after day, hour after hour, and there's no change at nighttime where it slows down, there's a lot of data that if the persistent heart rate above 110, for example, for weeks, will gradually, progressively weaken the heart muscle. And we could get in big trouble. Jen and I see that all the time. We've seen patients with who are ready to almost to go to a heart transplant, then you control the AFib and the heart muscle recovers. Most of that is recoverable. So
So you're
it's-
saying that, you know, if you have peaks of high heart rate, and then it can be reduced, your heart recovers in a few hours
Yeah,
from, okay.
the old standby procedure for that, if we're not gonna try to restore normal rhythm, is that how do we control the heart rate, either with medicine, or we actually put a pacemaker in, and a couple weeks later, we come in and cauterize the wire between the upper and lower chamber. It's called the AV node. So the upper chamber still fibrillates, it just can't drive the bottom fast. So what controls the heartbeat? Pacemaker.
Oh, the pacemaker.
That's a guaranteed way to control the heart rate. In fact, it was the very first procedure developed in interventional EP. Gallagher and John Gallagher and Mel Scheinman back in the late 80s developed that procedure, and it saved a lot of lives. It doesn't fix the AFib. The AFib still fibrillates, so you still have the stroke risk, but it basically instantly makes the heart rate controlled. So a lot of patients have had significant recovery of heart function with that we kind of view it as an end-stage procedure right now. But maybe somebody in here has had that though, huh? At least one or two patients have had it.
Come on again.
It's still a very good procedure. I mean, we fall back on it, you know. I saw a lady today who's been an AFib for a year. Her ejection fraction number is 20, and she can barely function, and she's not a heart transplant candidate, and we're going to ablate her AV node. Now, my suspicion is that when we control the heart rate, her heart function will get better. Very useful. It's a very simple procedure, too. It's not a really radical, high-risk procedure.
You ablate part of the attachment to the pacemaker?
No, so the pacemaker's there just to prop the heart rate up,
Uh-huh.
and it's put in, usually Dr. Zhao does it for us. Pacemaker's put in, you make sure there's no problems with the pacemaker, wait 2 weeks, and you come back through the leg vein, you cauterize the wire between the upper and lower chamber. Anybody ever drive a standard transmission?
Yeah.
It's like, if you push the pedal, the engine revs, but if the car's in neutral, it's not going to drive the wheels. And for some patients, it's life-saving. We still fall back on it sometimes. We don't like to do it, but it instantly gives you symptom control because your heart's not racing, and typically the heart function gets better, and then you get patients off all these poisonous drugs that makes them feel bad too. So in many patients, it's a very, very good strategy. It's usually when there's nothing else to offer, but it's very useful.
Does anybody, I'm new to this, my daddy recently had an episode, came here to emergency, but I still don't know where all this come from. He's 96.
He's what?
96, and if you see him, he looks pretty active, and he thought it was a cold. He had a pneumonia in 2015, but I don't know if this was undetected, all this from 2015. He had a wheezing sound, and we thought it was the pneumonia.
Well, I tell you, there's such a high chance if you develop pneumonia when you're older, you go into AFib. We see a huge amount of AFib when the pneumonia season's in. The inflammatory state of bronchitis or pneumonia tends to throw you into AFib.
So probably he wasn't in and out of that from 2015 to...
I don't know for sure, but my suspicion is that he probably was a normal rhythm, got pneumonia, and then went into AFib. Or he may have been an AFib, and the stress of the pneumonia just made him decompensate more.
Now it's in
96, we gotta make sure we don't hurt him.
Oh, jeez.
I'm clueless still.
We gotta make sure we don't, that Latin phrase, primum non nocere, first do no harm,
Right.
you know.
And then he had a cold, so he thought, am I here because of the cold? No, that is that it was his heart rate was high.
We see a lot of patients who come to the emergency room thinking that they've got pneumonia or cold, and they're short of breath, and what's really happened is they have undetected AFib, and they're in congestive heart failure, because when you go into AFib, you tend to build up fluid into your lungs. And so we see a lot of patients in the emergency room because of that. AFib can throw you into heart failure. All heart failure means you can have heart failure with a strong heart. All
Right.
heart failure means is that the heartbeat is not efficient and the fluid builds up in the lungs.
And that's what they gave him a Furo to eliminate fluid
Uh-huh.
3 times a week because we heard
He
that
built up with
there
fluid.
was, you know,
He was in congestive heart failure.
the last 2 years.
And they
I mean,
probably, a
and
lot of
it
patients
snores.
have both heart failure and pneumonia at the same time. It's kind of confusing.
Very. But they said
96.
the heart looked strong, like you said earlier. Well, the heart, they did an echocardiogram, it looked strong, but at that particular time, he had a cold, and that's why.
We gotta make sure we don't hurt him. We didn't see him, I'm sure. I haven't seen anybody in 96 for a while, but
I don't know if it was him.
Dr.
that
Shaw
came
may
in
have
the
seen
room,
him.
But somebody similar came into the room and he said, well, you're okay. And then we went to Dr. Deffer and he said, Dr. Deffer, your heart is strong, come back in 6 months. Gave him that to eliminate fluid, but then he has a weak bladder. So he was urinating more frequent. I asked the urology and said, well, I don't think you're going to interact with the
I
other
think I'd rather
drugs
wear
he
the
takes.
pad and not be sort of breath.
96. It's scary.
Congratulations to him.
Yeah.
We gotta make sure that we don't hurt him. It's easy to do in this field, it's easy to get trapped into doing more and more and more when the solution is really to do less. He and I are constantly amazed by somehow our best efforts are thwarted and all of a sudden it's time to back away. I think that takes more skill sometimes than to get more aggressive.
And he'll continue to walk, it's just like, moderate, but he walks. That's what I kept him to 96. He walked distance.
Somebody had asked me before about what's the current status of the devices if you can't take the blood thinners, the current devices. That, remember we said that when you go into Afib, you can form blood clots, and the blood clots come from that little pouch called the appendage. There's been a lot of advancement now with these devices that can seal off the appendage. And currently there's 2 major ones that are being done. One we do here at East Jeff is done with Dr. Brothers. It's called the AtriClip. And what the AtriClip is Dr. Brothers makes a little incision here in the side of the chest. And if the incision is placed just right, he can, with a scope, find where that little pouch is and put a little rubber band type device called the AtriClip and basically seal it off. And it's called the AtriClip, ATRI-CLIP. Jen and I have sent a variety of patients. I think we've got about 7 or 8 patients recently that we've sent over. And he's gotten very good result with that. It's minimally invasive. And basically, we believe that once the healing has taken place, you don't need to be on the blood thinners. So I anticipate there's going to be a growing number of patients who have had either bleeding or bad side effects from the blood thinners that are going to want to pursue that. The other option is a device called the Watchman. Anybody's heard of the Watchman device? And the Watchman device, you actually go in through the leg vein and you deploy an umbrella type device. Okay, it looks like a little mini umbrella, and the tissue grows over it and basically seals it off. We're not offering that right now here at EJ because of cost considerations, I believe. But we are working with a group at Tulane, and Ochsner has it also. So it is being offered. So those are the 2 basic types of devices that are, and you're going to see those grow a lot because more and more we're seeing patients who've had a major bleed from being on the blood thinners, or again, they're on multiple blood thinners and they bleed. Some patients have bled into the brain, and it totally precludes us ever going back and using blood thinners, and they're at risk. So those are the patients that tend to get the AtriClip or the Watchman. And we've been pretty satisfied with we don't have 5-year follow-ups on it, but I think that's going to be the wave of the future in patients that we can't fix AFib, and patients don't want to take the blood thinners or have been having problems with the blood thinners, that they get one of those types of devices. Yes, ma'am?
How long can you take blood thinners before you either become immune to them or they'll start having problems?
You don't get immunity to them in the sense you think about immunity. but you can take blood thinners long-term. Now, every year you take the blood thinner, there's a slight cumulative risk of bleeding. Bleeding risk always adds up a little bit each year. Now, what you're basically doing, as we talked about before, you're trading, when your doctor sits across from you and prescribes a blood thinner, there's an implied contract. That is, you take this to prevent a stroke, but we're going to accept this as a bleeding risk. That's always the implied contract. And we think that we can handle a bleed a lot better than we can handle a stroke. So it's choosing the lesser between two evils. They're both evil. I mean, having to take the blood thinner is bad. Even the necessity of having to take a blood thinner is not good. I mean, he wouldn't want to be on one and I wouldn't want to be on one, but I'd rather take one than have a stroke. Because you've seen patients with strokes, they're not, I like to use the phrase, what made you you is gone a lot of times. Yes, sir, I'll come back to you. Yes, sir.
They won't do an atrial clip unless you have a bleeding somewhere?
Right now, with the current indication, you have to have not be, it's going to change. One day it's going to be patient preference. That's why more and more people are going to have it. Right now, the current indication is you'd have to have been intolerant of or had a major side effect to the blood thinner. But what's going to happen within a few years, it's going to be patient prefers one strategy over another. That's why those numbers are going to grow. The trouble is we've had here, and I'll be honest about it, is the hospital's had some financial difficulties, and the cost of providing that service, they don't deem to be acceptable right now. They would lose, they tell me, I'm not a financial person, but they tell me that they would lose money on it, and they don't want to do the program.
So what are the symptoms of a brain bleed?
Oh, it's a stroke-like symptom.
Oh, it is.
Severe headache and/or loss of function of a limb on one side, or you can't get words out. So those, if you ever, in fact, maybe you want to go over those symptoms of what a stroke is, because if you ever get those symptoms, you got to get to the emergency room as fast as you can possibly get there. Okay? If you start losing feeling in a hand, or you can't move a limb, or sometimes it's very subtle. A wife or husband will say, "Why is your face drooling?" Okay, or why is your face contorted a certain way? So even subtle things like that. When in doubt, get to the emergency room as quick as you can, because if you get there early enough, they can intervene and save brain. Just like for a heart attack, you got to get into the cath lab within 90 minutes. You got to get to the emergency room within about an hour. Strokes are devastating. And as we said before in the support group, if you are on a blood thinner, it doesn't mean you can't have a stroke. You could also have a bleed. So that's there's always something waiting to kind of latch on to you. But whenever you see anybody, all of a sudden they can't move a limb, or they can't get their words out, or they're mumbling words, and they haven't had 3 drinks, you know, get them to the emergency room. But those are technologies that are coming around, because the data seems to say that if you get the AtriClip or the Watchman, and they've not been pitted one against the other, unless Jen saw something at the meeting. I didn't see anything. But unless you get one of those strategies, if you get it, it's as good as being on a blood thinner. It's not necessarily better, but it's as good as. So it's considered a reasonable substitute. And a lot of patients are going to start asking to get off the blood thinners and try one of those strategies. It's common.
So there's a limit, like, it's a procedure according to the doctor, like who's qualified and...
So to put the Watchman device in, it's usually a collaborative effort between the interventional cardiologist or the electrophysiologist. In some places, it's just the electrophysiologist, because to do it, you have to go in through the leg vein. We usually use the right leg vein, and that takes you into the right side of the heart. Where does the left leg vein take you? Into the right side of the heart. They join like in a triangle. So when you get into the right side of the heart, the appendage is on the other side of the heart. So how do you get there? You have to do a little needle puncture under ultrasound to make sure you stick in the right spot, not punching a hole in the heart. You slide the little plastic tube into the left side, and then you deploy the Watchman device. If
Is
you have
that
the
through the
atri-
septum?
What's that?
Do you go through the septum?
You go through the septum. Yeah. You cringe.
Well, I've had septal alcohol ablation
Yeah.
before a fixed septum.
Oh, yes. No, you had, that's on the bottom part of your heart, though.
Oh, is it at the,
Yeah, that's the
Okay.
bottom part. You can still have that.
Oh, okay, well, it's nice to know it's an option, thank you.
Yeah. No, that was for the thickened heart muscle. That's on the
Right,
bottom part.
right.
The septum is in the upper chamber. So you could still have Watchman.
Okay,
I think the number of Watchmans is going to grow a lot. And there's even a better device. There's another company making an even better one. It's a very active area. But I could see the day where we're less aggressive at trying to fix AFib, and we're more aggressive at preventing stroke risk with those kind of devices. So I think those numbers are going to grow.
what
Provided the
about
hospitals can afford it.
the AtriClip? I mean, is that through the septum also?
It's, no ma'am, that's, the AtriClip is done externally. In fact, that actually adds a level of safety. Dr. Brothers makes a little incision here.
Uh-huh.
If you think about the layers, you go through the skin, the muscle, in between the bone, and right underneath there is the heart. He makes a little nick and opens the pericardial sac. With the scope, he sees it, he grabs it with a little tong and slips the device over it. It sounds radical to have it, but it's actually very simple and we think it's pretty safe.
What does the insurance company think about, you know?
It's too expensive.
Well, we fight insurance.
Yeah,
Don't get me started.
Because you can. I
This
can
poor
come to
lady,
you
she
and
goes
say-
nuts with insurance companies. She's the one that's got to go deal with them.
I can come to you and you can give me a pill that'll do the same thing as this $50,000 operation. So is the insurance company gonna be open to me having a choice one day to pick one or the other?
They pay for
That's-
it now for the ones that have it, yeah.
Yeah, but the ones that have it are ones who cannot take it.
Right.
They may in the future, depending on the policy, say you have to take blood thinners for the rest of your life. You won't have the option. That could happen because the devices are expensive. Now, the AtriClip's not that expensive. AtriClip, other than the surgical part, is the device is not expensive at all. It looks like a little rubber band. I mean, Dr. Zhao he talked about that a little bit at one time.
Yeah.
It's a little device. It's not much bigger than a,
The
maybe a
second
thick rubber
generation
band.
is much better.
What's that?
The second generation product is now is more smaller
Yeah.
and more easily maneuverable.
You went in on the last one. It was about an hour case. It's about an hour procedure.
Yeah, probably. We have a one this week, so before we finish the converting, we already finished.
Yeah.
Yeah, he's so good at it.
So is the Watchman better than the H?
We don't know. They've not been.
Oh, they haven't-
To answer questions in medicine, there's a gold standard. It's called a randomized clinical trial. And what they do is they divide patients up, and one patient goes to that group, the other patient goes to that group. They're kind of matched according to age, sex, different factors. They do one thing in one group, one thing in another, and then they track outcomes. In this case, they track strokes. There's never been a randomized trial looking at the difference between them. At least not that I'm aware of. It may be in other countries, I'm unaware of it. Yes, sir?
Going back to the stroke risk, is there, I think in an earlier session, there was a little conversation about some way to notify emergency rooms if a patient goes in with the symptoms of a drooping face or a pain in the arm. Is there an easy way to communicate that, I'm an AFib patient and I'm taking blood thinners, so I don't know if I'm having a stroke or if we've got a bleed going.
So you're worried about if let's say you had those symptoms, you couldn't get the words out, and
I guess that plus just some easy way to communicate. I'm worried about going to an emergency room that doesn't know what to do. That's what I'm worried about.
that's a problem.
Yeah.
That is a problem because some of the emergency room doctors, most are well-trained, but mistakes have been made. Yeah. In the ideal world, you'd have a small, tiny device like I'm a huge fan of the Link device. I think if I had AFib, and one day I'll probably get it, if I had AFib, I would want a link device in me. And who has a link device in this room? Okay? But you could see in the future, and I think, I haven't talked to the engineers, but you could see in the future that you'd have some way to maybe tap alert and communicate some problem, and the emergency room would be forewarned that you're coming in. It's not there yet. But I mean, this is the area of artificial intelligence and, you know, Internet of Things, and you're gonna see these devices get a lot smarter.
But I think the loop nice ability for ER, a lot of ER physicians, before the patient arriving, the Medtronic already send fax the information.
Yes. Like Dejal was saying, is that the current device can notify, but it couldn't tell you, for example, you're having a stroke. You'd have to maybe touch some alarm to tell them that.
And hope that there is a stroke team here at this hospital, and they are stroke affiliated. They have
Do we have
certification.
a stroke team?
There's a stroke team.
We have a pretty good
There's a
stroke
stroke
team.
team
There's
here.
an excellent stroke team at West Jefferson. In fact, one of the guys there, Dr. Dawson, saved one of our patients one night, a famous night on a Friday. Dr. Zhao made a ride over there. There's a world-class interventionist there, and the people here are very, very good too. Ochsner has one. Some of the hospitals don't.
Are there any on the North Shore?
I don't think so.
And then there's no more heart hospitals.
There's no more heart hospital. I don't think there's an acute stroke interventional unit on the North Shore. It takes a lot of manpower and a lot of cost, because to man that, you've got to have people within a very quick distance ready to come in at a no moment's notice. But I think these devices are going to get better. Like Jen was saying, you know, if you've got VT, for example, a device would automatically download that and tell the emergency room a lot of times. So this is getting better and better.
Well, if you have a pacemaker, can they tell from the pacemaker that?
Every company has an alert system. In fact, there was a recent review of that in the Journal of Clinical EP, or was it JACC? Every company has a system now that could send automated alerts to the company. And some of the, I know Biotronic, for example, it's manned 24/7.
Medtronic too.
Thanks.
This depends on your input doctors.
It depends on how the alerts are set too. Your doctor has to, when you come in and get programmed, that's a good question, because you could ask the rep, what alerts are programmed on for me? That's a good question to ask when you come in. What alerts, what will be automatically sent to the doctor and at what time frame? Those are good questions to know. And a difference for each manufacturer. St. Jude has the Merlin system, Biotronic has their system, Medtronic has their CareLink system. Every company has their own system. They're not all the same.
Do you have to be near your device to do that?
Typically, yeah.
Oh, okay.
You should have a workstation nearby your
You did. You did.
Yeah, I do. I
So
have.
there usually is about, in the midnight, will automatically download the information, transfer to the company centers. But whether they download this information or not depend on the physician who put the device in.
Oh, okay.
To set up the alert threshold.
And there's only one
I know
physician that
one company's
watches it.
experimenting with a system where if you felt symptoms, you would get a telemedicine instant consult from your home. A couple of them are working on that. You could probably expect that in 5 years. Within 5 years, they'll have the ability to tap something and say, I feel terrible, you know, and get an instant, like, face-to-face referral with somebody to guide you. That's coming. That's going to be nice, because it's going to be great for patients. It's not here yet. Any questions about this, ma'am?
I have a very simple question. I'm getting ready to have the cryo balloon,
Mm-hmm.
and is it general anesthesia? Or, I'll be asleep.
You'll be totally out. Most patients want it that way.
I do.
Some centers don't. Some centers don't. They use conscious sedation. I think that's kind of,
In the Europeans and in Asia, they just use conscious sedation. They not use general. They read like generally written they would be.
there's a huge amount of pressure on us to cut the cost of the procedures.
No.
We haven't succumbed to that. We still use general anesthesia.
Well, I'm past that, I'm past the point of wanting to see everything.
It's not a painful procedure. It's you know, it's not painful.
No,
I mean, most patients are awake, you know, right after and are walking 4 to 6 hours later. So it's not considered a painful procedure at all.
how long does it take?
Typically under 2 hours.
And what's the recovery time at home?
Well, we wouldn't, because of the puncture site in the leg is fairly large, we wouldn't want you doing weightlifting or bicycling or golf or anything. But typically you could resume household activities like a day or so after.
Oh, okay,
Recovery is very quick.
yeah.
In fact, for most of the procedures now, the convergent is a much bigger procedure. It's got a lot more downtime. Typically a 4-day stay, 5-day stay in the hospital. Patients take a little bit longer to recover from that. But the cryoballoon itself is a very simple procedure.
Do most people have trouble with having a leg flat for like?
Some do, particularly if you're prone to chronic back pain, for example.
Right.
That position is uncomfortable and you've been on a hard table for a couple hours and your muscles are kind of relaxed, so most patients tend to have a lot more aches and pains.
Right.
So some patients it is a little bit uncomfortable.
Okay, 'cause
But we have chemical solutions to that.
oh, because I know ahead of time it's gonna be a problem, yeah.
Yeah. The cryoballoon, we're big proponents of it. Some centers believe they would rather do the radio frequency, particularly with the contact force sensing. The advantage of radio frequency over cryoballoon is that you could make a wider circle around the veins, and some people feel that's important. So the what's called antral isolation can be extended back, but there's ways to get around that with cryoballoon. I personally think the risk with the cryoballoon is much safer in terms of the dreaded complication, which is a hole between the atrium and the esophagus. It's the most feared complication of doing catheter ablation. Because when you think about it, if you look at the heart model, I like to show patients the heart model when I'm in the clinic, and the esophagus is right behind that left atrial wall. So if you start burning in that area, it's technically possible to burn. One way to think about it is you literally burn a small hole between the atrium and the esophagus, and over a period of a few days, that enables a communication. And so what happens is esophagus contents get thrown out to the brain through the atrium, and it's not very good. It can happen with cryo, but it's very, very, very unusual. It's much more common with radio frequency. And we consider that the most dreaded complication of an ablation procedure. It's on the order of about 1 in 1,000 to 1 in 5,000. It's hard to tell because some people don't report it. I mean, there's no standardized registry. There's an effort now to get an Afib registry where everybody reports, just like the heart surgeons do. They report all of their successes and all their complications. I think a good lab, that's what we're going to try to do in the future, is try to get our lab certified, which will be a meeting between Jen and I one day soon, I hope. Try to get our lab certified and participate in a data registry. We don't participate in a data registry right now. The heart surgeons do. Every heart case in the city of New Orleans, for the most part, is reported. Every case is reported to a central collection agency. You can look that data up. It started in New York. You can look up every heart surgeon's success rate, complication rate by surgeon. It's a consumer protection. Any other questions? Yes,
I
ma'am.
have one more. So is it better to see a specialist on AFib or a cardiology?
Well, that's kind of
That-
we
I
have a
don't-
biased. We have a biased answer to that.
I need to know because I'm not saying that one or the other don't know what they're saying, but it's more specific since.
My cardiology colleagues would probably say they can handle AFib as well as we can. It's like anything, the more special, I mean, when I have a problem, I go to a specialist. That's just my point of view, my philosophy.
Right.
This is all Dr. Zhao and I do is manage AFib. And and we're up in the latest, greatest. If you gotta handle coronary disease and hypertrophic cardiomyopathy and valvular heart disease, I don't think you can be as good unless you're specialized.
Right.
Now, we work closely with our cardiologists. We almost never do anything. If you have a cardiologist and you come to us independently, we wouldn't do anything without calling them. Or, you know, and in some cases, they raise valid concerns, like, I don't want you to do a procedure because of A, B, or C. We tend to, then would sit down with you and say, you know, your doctor's expressed concerns and maybe we shouldn't do it. We had one lady who had a rare condition called cryoglobulinemia, where the blood proteins would coagulate, and she didn't remember it as I remember, and her cardiologist pointed it out to me. So we did not do a procedure on her. So we tend to work very closely with the cardiology, but the question you asked me was, if you have AFib, do you think it's better to go to an AFib specialist? And my biased answer would be yes.
Yeah, well, at that time, at that moment, I said, they asked me about cardiology, and I said, I followed what my mother had, Dr. Teffer. And I said, I guess Dr. Teffer, I said, I didn't, because we had never encountered this situation.
Well, most of them send to us on a fairly regular basis. Some of the cardiologists have different opinions. Some are not as big a believer. I don't think you can give counsel to a patient unless you actually do the procedure. I mean, I wouldn't feel comfortable counseling you about whether to have an angioplasty.
Right.
Because I'm not in the lab doing angioplasty. I wouldn't be able to tell you what my success rates and complication rates would be. So for that reason, I think it's better to go get an opinion. It doesn't have to be necessarily have to stay with that person, but you should at least get an opinion from somebody who does it every day. And I think one of the things we pride ourselves on is I think we're very fair, and we don't try to push people. There are people who just say, oh, you got to go have a procedure. I mean, Sharon comes in the room with me all the time, and she'll tell you we never tell people that. We offer it, we educate you about it, but it's always because it's a risk. You know, the decision's easy if you got a procedure with 100% success rate and no complications. Right? It becomes easy, but when it's like 80% and there's some complications, it gets more difficult to make an informed decision.
Is there any gender difference in treatment of AFib?
Yes.
Yeah, please.
Well, there's, Jen, you want to touch on that? I mean, gender difference?
Gender difference.
In the treatment
Well,
of AFib, is there a difference between how you treat men versus how you treat women?
Yeah, there's some data that suggests women may not do as well.
As men, right?
Yeah, and there's also data that suggests that women tend to, I gotta be polite how I say it, women tend to be ignored a little bit less, or rephrased maybe, the more aggressive options are not, I gotta be polite, I gotta be careful how I say it. Women don't tend to be treated as aggressively, meaning offered the full spectrum of options. That's been studied.
Same with coronary artery disease too.
Yeah, same thing with coronary artery disease. I had a patient I saw today on the West Bank, and she told me her daughter was seeing somebody else. Daughter's 20 years old and keeps going in with palpitations, and they find SVT, and nobody's even told her there's an ablation option. I think that's wrong. I mean, ablation's listed in the American College of Cardiology as frontline therapy. So women tend to get blown off maybe a little bit more.
Is it due to cost? Is it due to, because still, and I'm only saying this as everybody may or may not realize, in the South, men are still the breadwinners?
There's a definite gender bias toward treatment. And you can look it up in any study.
And is it just in the South, or is it
No, it's
universal?
nationwide.
Nationwide or universal?
Yeah, I don't know about the geographical differences, but it's nationwide. It's a generalized phenomenon. So if you just punch in, yeah, if you go to Google and punch in gender bias, AFib treatment, you'll find a bunch of references to it.
So I guess our question wasn't, am I being undertreated? That is not the issue. It is,
Are you being treated properly?
would you treat a woman's AFib differently than you would a man's, if they had the same symptoms?
There's one thing I would worry about. If you look at complication rates, more frail elderly women tend to have a lot more complication rates. Small stature, low body weight. There's some pathologic studies suggesting that there may be a difference in the thinness or thickness of the left atrium, maybe predisposing to complications. So there are patients, I just get a gut feel about who may have a complication, and so a more frail, older lady, I might back away from a little bit more.
Is it possible that females have different trigger areas?
Yes.
Slightly?
Yes, and there's a definite role in estrogen on AFib expression. Testosterone and estrogen have some influence on AFib expression. For example, men who are testosterone deficient tend to have more AFib, and if the testosterone levels are restored, they tend to have less AFib.
What if I took testosterone? Would that help me?
There's actually maybe.
Hey, I'm desperate.
I saw an abstract. I'm not an expert on
Just
that.
start talking to you in a deep voice.
Yeah, but definitely there's some factors about AFib expression in women versus men. But in general, most of the studies suggest that women tend to get a little bit slightly. The success rates may be not quite as high, but they're pretty close. There's not a huge difference. We in particular don't discriminate. We would just as likely be to recommend AFib procedure for a woman as for a man, except in that, again, that maybe older 70 to 75-year-old lady who has a body weight of about 100 pounds maybe, or they're very small and frail. I personally think the complication rates, when we look at our own complication rates, seem to be higher in that subgroup. So we go into it with a lot more caution. So the answer to your question is yes, there may be some slight differences.
And then we have the southern diet, how many 100-pound women?
Yeah, you're right.
I'm not
Actually,
being smart, I'm being serious.
yeah, no, we do see a fair number of them actually.
You know.
Yeah. I mean, just think about it, because it's mainly to do, the complication rates have to do with the thinness of the wall too. The wall is very thin. Remember, you're taking a fairly heavy piece of equipment, even though it's over a guide wire, it doesn't take a lot of force maybe to, sometimes the atrium is so thin on the pathology specimens that are published, the light actually shines through the wall. That's that thin. So you can envision, maybe it doesn't take a lot of manipulation to punch a little tiny hole. You know, you punch a tiny hole in a balloon, particularly when you're on blood thinners and the blood rushes out into the pericardium, it could be a catastrophe. We've had our scary moments, believe me. All right, so we covered a lot of stuff. I do have the article. I wish I would go read this. This is really good, and it dispels a lot of the myths you see advertised, particularly about antioxidant vitamins. Next time, we're going to talk about...
We don't know.
We don't know yet, okay. What do you want to hear about?
The open forum is nice.
You like open forum?
Yeah, I really did. That was roomy today.
Okay. I don't, again, there's no big revelation in new stuff coming. I mean, the field is right now kind of static, except for the occlusion devices, for the appendage. I think they're going to see those grow a lot. And I personally think they're very useful.
Can I ask one question about, when I get off my AFib and get back into normal rhythm, would you be prone to taking me off my Xarelto?
No.
Stay on it?
The studies are very clear on this. You know, there's actually no guideline offering doctors advice. I mean, thought leaders in AFib have lots of opinions, but when it gets to that topic, everybody is afraid, because it only takes one long spell of AFib to cause a stroke. So people are afraid of the legal implications of that also. And once you've had AFib, we don't actually know when we can take you off the blood thinners. There's no scientific evidence that guides us. And it's really a gap in our knowledge right now. We don't know. But we would tend to, for a minimum, I don't know what Jen's policy is, but for me, a minimum would be 6 months on a blood thinner before I'd even think about it, to be back in normal rhythm. And even then, we don't know.
And actually, when you calculate your risk factor for stroke, it's not because the AFib itself. It's more like the risk factor to trigger AFib. It also give you the risk in the future for stroke. So when you see when some people with AFib with ablation, you put the chips in, the patient coming later for the stroke, we have 2 or 3 cases in the hospital. There actually no AFib for the chips or pacemaker document at that stroke, so you will know. It's not because the AFib itself. It's something else like hypertension is a risk factor for AFib, coronary disease, okay. So it's also give you the risk for increase the risk for stroke, even you are in the normal way.
So we're very reluctant to stop them unless you've had a complication from them.
Yeah, so, I mean, this AtriClip and the other thing, unless you can't take blood thinners, don't get one of them.
If you've had the AtriClip, we feel comfortable that it's okay to stop them after a while. Because the studies have suggested, we don't have as much data with AtriClip as we have with Watchman. Watchman's had 2 big trials. And most people think that if you've had some type of occlusion device, your AFib risk is about the same as you'd be on the blood thinner. So a lot of people stop them. Now what's happened is almost all the studies are in patients who've been intolerant of blood thinners, right? So there's some gaps there. But I can see this growing where patients, I mean, we get a lot of patients who have not had a real complication from a blood thinner, but for example, bump their arm and they've got the bleeding under the skin, the sub-Q bleeding, and they hate it. And then they've read about, or they see on the TV, 1-800-BAD-DRUG or bleeding, and they're terrified about the bleeding risk, and there's a lot to be worried about. And we get a lot of patients, and Jen will tell you the same thing, that come in and say, I'll do anything, I don't want to be on blood thinners anymore. And they've not had a major bleed, they've not had any cerebral bleed, they've had no major bleed, they just want to be off the blood thinners.
So what do?
I beg them to stay on them.
Well, I mean, it's just you hear so many things about bad drug. I mean, so the thought is, don't take drugs. So if there's a way not to take a drug, then maybe a device is the answer, but.
Well, I can see the devices growing for that indication. People, so the indication would be of want of avoidance of the blood thinner. That's why I think that's going to grow a lot. Yes, ma'am?
I've only had like a few AFib events, no procedures, and they were short. Do you ever consider taking someone off, say the rhythmol, to see if they have more?
I do, because otherwise you commit somebody to a lifetime of, remember AFib in general doesn't kill anybody. It exerts its evil, if you want to call it that, by virtue of its stroke risk. But let's say you had a big, let's take an example. A patient I saw recently had a major stress in their life, had lots and lots of AFib. The stress resolved and the AFib just got better over about 3 months. And then has been 6 months on propofenone and has had no problems. And those type of patients where there's some attributable cause of the AFib and that cause is maybe remedied, I will many times stop the antiarrhythmics. Yeah, otherwise you're committing somebody to antiarrhythmics for the rest of their life that may not need them.
Would you put them on pill-in-the-pocket type therapy?
It depends on the symptoms. Many times we do have that strategy to use. So in the pill in the pocket, we use a lot for travelers that have sporadic, unpredictable AFib, and they want to avoid a emergency room in Italy, for example. We'll give them 2 or 3 propofenone tablets and say take it only if you go into it. It works a lot. We use that strategy sometimes. Okay, so we're gonna try to dream up something interesting for next time,
Thank you.
okay?
Thank you, Professor.
Thank you
You're
very
welcome to
much.
take these copies.